Hi everyone, my name is Mukhadi Koko. I am part of RSN. I'm one of the events management workers. We're so excited for this talk. I'd like to welcome everyone present from the students, the speakers from SATP and Dr. Ben. I'd like to start off by saying Happy World TB Day. Did you know that World TB Day is observed on the 24th of March because in 1882, Dr. Robert Koch announced the discovery of Mycobacterium tuberculosis, and this discovery is believed to have paved the way in effectively diagnosing and treating TB as a disease. After this great discovery, every year on the 24th of March, talks and events are held to acknowledge the progress in TB research and to raise awareness about TB, especially in the rural healthcare setting. What is special about today's event is that it is a collaboration between SATP and RSN. SATP stands for South Africa's Tuberculosis Vaccine Initiative, and their mission is the development of new and effective prevention strategies against TB, including vaccination and biomarker-targeted treatment approaches. They are involved with projects to address critical clinical, epidemiological, immunological, and human genetic questions in TB pathogenesis and vaccine development. We have four very important speakers with us tonight. We have Dr. Ben Gont, Dr. Simon Mendelsohn, Professor Tom Scriba, and Dr. Pia Sagler. I hope I pronounced all your names correctly. We are very grateful for you joining us today, and we look forward to everything that you have to share with us. We will have a Q&A session at the end of the talk, so should any of the speakers have a question, should any of the listeners have a question, please feel free to ask them in the chat. Without further ado, we would like to introduce our first speaker for the evening. So to start us off, we have Dr. Simon Mendelsohn, who has worked in the Mpumalanga Department of Health and spent 6 months implementing HIV/TB programs in Malawi prisons with Médecins Sans Frontières. Today, he will be sharing his experiences with us, specifically how his experiences led to doing research with SATP.
I think you're going to have to enable, thanks very much for that introduction. It was a great introduction, and that's exactly what I'll be presenting. I can't seem to share my screen. It says host disabled Austin screen sharing. Is there any way to enable that? Otherwise, I can email the presentation to someone quickly to put up.
So Simon, I just made you temporary co-host, so you should be able to share your slides.
There we go. Got it. Thanks, Pia. Yes, I can now share. There we go. And you should now be able to see World TB Day 2021. The clock is ticking. Can everyone see that? And can everyone hear me?
Yes. Yep.
Super. Okay. So yeah, I think that was really nicely summarized. I'm going to just present some of my experiences and how I got from being a clinical medicine doctor working in the ward and a few experiences rather working in prisons as well, to how I got to doing experiments on the lab bench. So just a brief TB journey, and in brief, it's only over the last 10 years in my clinical experience. So first of all, I'd like to start off just for the RSN people who organized this talk, just with some photos from my medical school days when I was a member of RSN, and these are some photos I found back from 2008 from my Rural Support Network elective in Queenstown, which I've got very fond memories of, and probably that exposure to rural medicine is what planted the seeds of working in rural areas and passion for rural health as well. So I think those projects are still really important. And in following years, I also went on with Shawcode on various rural electives as well. And you might see some familiar faces there. Some of them are now consultants at Krutsky and other places, including Dr. Huang over there. Okay. So now on to the matter at hand, so tuberculosis. So when I was at medical school, and this was in the mid to late 2000s, so relatively recently, there was another epidemic that was peaking in South Africa, and that was at that time the HIV/AIDS epidemic. So when I started medical school, ARVs had recently been made publicly available, and this was during the infamous reign of Mantashabalala Msimang, who's infamous for her potatoes and garlic and beetroot regimen for ARVs. However, while I was at medical school, rollout was still slow in the early stages, especially in rural areas, and there was still significant stigma associated with HIV diagnosis and treatment. The result is that my memories of medicine at UCT are wards at Somerset Hospital, at the old GF Jooste Hospital, full of HIV positive and mostly HIV positive TB patients. And arriving in Mpumalanga for my internship 6 years later, things were a little different, with advanced HIV and TB patients still lining the corridors and filling the wards. And it was quite a routine occurrence while I was in Mpumalanga, while I was an intern and junior doctor, to fill out several death certificates every day for anonymous individuals coming with HIV and TB victims who were mostly undiagnosed HIV positive. They'd come to hospital and were only diagnosed in the emergency department. And by that time, these patients with advanced HIV and TB, there was little that we could do. So coming in with CD4 counts near zero, some with no CD4 count at all, with advanced or disseminated TB. And even if we had started TB treatment and treatment for other opportunistic infections immediately, the evidence shows that likely it would have had little effect. The mortality rate certainly in Rob FERREIRA Hospital I worked, but in other places as well, was staggering. So it started becoming apparent that what I was seeing in the hospitals was just the tip of the iceberg as well, that these were just the patients with advanced HIV and TB who were making it to hospital, that many more were dying at home. And what we were seeing was this perpetual downstream flow of advanced HIV into the hospital, but what we were missing was the upstream flow. And clearly what is happening is that while we were treating these advanced patients in hospital, that the system was failing miserably in the clinics and certainly in the rural areas. The questions were, why were these patients not on ART? Why were they arriving in hospital with such advanced TB and HIV, and why were they not being diagnosed in the clinic? In fact, why were they getting TB at all? So those were the major sort of thoughts that, things that crossed our mind while we were working there, but you just didn't have time to figure it out because you were desperately overworked as a junior doctor. So hold this picture for a moment, this picture of these hospital corridors and patients with advanced HIV. And I'm going to digress for a moment to where I worked a bit, as I mentioned, I worked a bit longer in Mpumalanga, and then I moved and studied a bit in the UK. But then I fulfilled one of my lifelong dreams of working for MSF, Doctors Without Borders. And for my first posting, I opted to work in Malawi, and the project there was to help set up HIV and TB programs in the Malawi prisons. And to give you some perspective, I've got a few photos of the prisons. These large prisons, some of them held up to 2,000 or 3,000 inmates. There are a few smaller prisons as well. In this large prison over here in Lilongwe, it had close to 3,000 inmates, of whom about 1 in 5 was HIV positive. The rate of HIV was a bit lower in other prisons, but most of the inmates were not diagnosed with HIV. They were not on treatment. And looking at the pictures, you can see that the prisons certainly reminded me somewhat of concentration camps, with these sort of barbed wire fences, the muddy turf, and inmates staying in barracks. The inmates were also a mix of minor crimes, petty crimes, who'd been given extended jail sentences, and a number of, in fact, hundreds of thousands of inmates who were on remand and waiting court appearance for months to years. And some who had been forgotten in the system. Just some other photos of just to show you the courtyard in one of the prisons and the barracks. And this is just an example of the food that inmates were getting. So in most of the prisons, inmates were fed 1 meal a day of nzima, which is like a hard form of pap. Some days they'll get no food if there was no electricity. And if the inmates are really lucky, 1 day a week they'll get some red beans, and wealthier inmates would get food from outside of prisons. So as you can imagine, there's a massive problem in these prisons of malnutrition, and every week we'd see a dozen or more cases of pellagra, which is a form of vitamin D3 deficiency, and some with much more advanced disease needing hospitalization. The cells that I mentioned, these sort of barracks-like cells, were also massively overcrowded, with some cells holding 150 or more inmates. Most of the cells were designed to hold 50 inmates, so that they were 300 to 400% overcrowded. The result of this was that inmates were literally sleeping on top of each other. So I've got a picture coming up here of inmates at night, but this picture here is during the daytime in the sick bay in one of the prisons, and this is a relatively spaced out cell, a relatively spacious cell. So this is one of the cells during nighttime, and as you can imagine, this is ripe ground for the spread of TB. So due to the malnutrition, the HIV, the overcrowding, and no people with HIV not being on treatment, we found that TB was rife in these cells. So the very sick inmates would be transported to hospital for testing, but little was done for those with a mild cough or chronic cough, and mostly is attributed to smoking, colds or flus. So inmates were really waiting until they were quite ill before they got taken to hospital. There was no doctor in these prisons, so they had to wait to go to hospital to be seen, and that was usually quite late. So we instituted mass screening in these prisons using symptom screening and portable digital x-rays with confirmatory gene expert testing. And sure enough, when we instituted this mass screening, we found a very high rate of gene expert positive TB. So the rate in the prisons varied between about 2 to 4%, and depending on the cell occupancy, we found a much higher rate, obviously, of TB in cells with a much higher occupancy. So cells with 200 plus people had prevalence close to 2% of TB, and this was mostly undiagnosed TB. So what became clear, and getting back to the TB HIV epidemic in Mpumalanga that I saw, and working as a medical student with the high rate of TB in Cape Town, is that what we are seeing is just the eye of the storm. We're just seeing those individuals with the clinical symptomatic TB who are sick enough to seek healthcare and actually are sick enough to have TB in their sputum. Most of the individuals who make it to hospital have advanced disease, and what we're missing is we're missing those people in the community who have mild or asymptomatic disease. And potentially it's those individuals with mild or asymptomatic disease who are perpetuating transmission. So if we want to eliminate TB, we need to do better. We need to interrupt transmission and reduce the size of the TB reservoir. We need to pick up TB earlier, or preferably prevent TB disease through vaccination or through preventative therapy. And so then, moving on to my last slide, that's what sort of drove me or moved me to work for SATV. Was one of the problems is basically we don't have enough good enough diagnostic tests. So just looking at this figure here, we have time on the x-axis and a spectrum of TB from latent infection through to incipient disease, subclinical disease, and clinical disease. And those are defined by MTP quiescence, having an IGRA or tuberculin skin test positive, increasing MTB replication, subclinical disease defined by sputum, which is positive for MTB, and clinical disease, which is a symptomatic disease. And mostly what we're picking up in the hospitals and in the clinics is people seeking care with the symptomatic disease. What we're missing is the subclinical TB. And the problem is that while we've got good screening tests for symptomatic screening, we don't have really good tests for subclinical disease or for anything for incipient disease. So with that, without much ado, that's where I arrived at SATV in 2017 to explore this problem and try and find tests for incipient TB and subclinical disease, which we can use for community-based screening and screening in places like prisons to pick up this TB earlier and interrupt transmission. Okay, I think I'll end there. Thank you all. And I think we get questions at the end of the talks.
Thank you for that, Dr. Mendelsohn. I think that was very informative. Thank you for sharing your experiences with us. Our next speaker is going to be Professor Tom Scriver, who has done incredible research with SATV, and today he will be educating us about the importance of research in TB clinical tools to eradicate TB.
Thank you very much, and it's a real privilege to be invited to speak here. Let me just see if I can share this. I hope you can see that. And let me just get a pointer. I presume you can hear and see? Yes, okay, great. Yeah, so what I thought in the next 20 minutes would be to speak a little bit about the epidemic as a whole, which I think is appropriate on World TB Day. And then also to highlight just a couple of ways in which, or basically highlight a couple of the issues that we face with TB and why it's such a difficult problem, and a few snippets of the kind of research that we can do to try and advance our progress. So this is what's on the menu. It's basically how big is the TB problem, what is necessary to control or eradicate TB, which is a very, very high bar, of course. And then just a few examples of how can research help. The size of the TB problem, I think, is underappreciated by most people on Earth. Certainly those who work in TB hear these figures a lot, but I think those who just don't grasp this problem. So it's estimated, and this can be contended. I don't know exactly how these figures were arrived at, but the estimation is that at least 1 billion people have died from TB. It's much more than any other disease that we're aware of. And TB, part of the reason for that is that TB's been with humans for a very long time. Certainly the earliest records of TB that we know of are from mummies that are several thousands of years old. There's also good evidence that the evolutionary tree of TB maps very well against the map that you can draw of human beings as they emerged out of Africa to other parts of the globe, which certainly supports the idea that mycobacteria that infect humans have been around for many, many thousands of years, probably 30, 40,000 of years, 1,000 years at least. So given that, it's suffice to say that TB is just an absolutely enormous problem, and that this bacterium is extremely well adapted as a pathogen to the human. How are we doing in controlling the global TB epidemic? Well, we're not doing very well. And there are many figures that you will hear being spoken of today. We should actually be hearing these figures every day, because TB is an everyday problem. We shouldn't only talk about it on World TB Day, on one day of the year. What this slide shows is an estimation from the WHO report on the incidence of TB in the blue line per 100,000 from the year 2000 until last year, or actually 2019. And you can see that there is a small positive, which is that this line is starting to come down, that the trend is downwards. But the global rate of TB is between 150 and 200,000 per 100,000. And of course, in other parts of in certain countries of the globe, this number is much worse. And I'll speak a little bit to the problem here in South Africa. So this is just not coming down fast enough. In fact, the WHO report includes the targets that we are trying to reach as a globe. So for example, the idea or the target was that between 2015 and 2020, we wanted to have a 20% reduction in the incidence of TB. We missed that target. We only reached 9%, which is that red part of the circle. We also wanted to reduce TB deaths by 35% in those 5 years. We missed that, of course. We only reached 14% of that. And so clearly, we're just not doing enough. And of course, what we know from the COVID epidemic that then hit last year is that when TB cases as a percentage of the January total were plotted over here in these graphs on the right for different countries, you can see that the number of TB cases diagnosed went down dramatically in a number of countries, including South Africa. The difference here is that in India and Philippines, for example, it actually started to recover somewhat, whereas in South Africa, it did not yet until June. And what this indicates is that presentation of people who need care to clinics where they would be diagnosed is not happening. And that's, of course, for various reasons, including fear of being infected with COVID, or just not having transport or being able to access care. And so unfortunately, we don't quite know exactly what the effect of COVID is on the TB epidemic, but it's bound to be bad, because many people who certainly would have TB are just not getting their diagnoses. And this is even worse than it is as in usual times. I wanted to also just highlight the fact that TB this is not a new issue. So I mentioned this thing that TB has been around with us for a long time. Well, this is a very interesting analysis that Robin Wood and Linda Gall-Becker did a few years ago, where they simply looked at the TB notification rates for Cape Town. Cape Town had pretty good records for TB notification for more than 100 years. And the gray bars are the rate per 100,000 people. And you can see that in 1910 to 1914, it hovered around 500 per 100,000. It maybe started to come down a little bit, but actually we're sitting at an even worse place now. So clearly this problem is not going away. Our current approaches are just not good enough. I think the one thing to highlight there is the case fatality rate, or the TB mortality rate, which are shown in the dotted line or the checkered bars, and those have become better largely because of TB drugs that have become available. But the mortality is still too high and unacceptable, and just much more needs to be done. In addition to this, we now have some of the best data on what the TB epidemic actually looks like in our country. So this was because there was the first national TB prevalence survey done in South Africa in 2018. The results were released only a few weeks ago. And I think there were two very striking findings. And the first one is just the incidence of TB that was seen. This is largely in an adult population, although the age groups did go down to 15. And so the overall prevalence was 852 per 100,000. So this is higher than the WHO estimate, and needs to be a wake-up call that we are seeing more TB than we thought we have in South Africa at this time. If you're interested, you can look at the breakdown. This report is publicly available. But I think the other thing that I just want to highlight, which Simon also highlighted in his talk, is that 59% of the TB cases that were expert positive, so microbiologically confirmed, had no TB symptoms. And so they were identified because they had abnormal X-rays, which then triggered sputum collection and testing. And so that is a really sobering finding. The fact that in South African citizens, there's an enormously large number of people that have TB disease that are probably transmitting the bacterium, but that are just not symptomatic. And because our systems for case finding are based on people presenting to healthcare because they are sick, means that we will be missing 60% of TB cases who should actually receive TB treatment and to protect themselves and those around them. So I think the one thing that we are learning from COVID is that we cannot eliminate this disease or get on top of this disease with a single approach. This is the Swiss cheese model that was developed by Dr. Ian Mackay for COVID-19. And for COVID-19, we really are doing a lot of things. We are wearing face masks, we are social distancing, we are doing infection control, we are cleaning surfaces, we are obviously now rolling out vaccines. So there are many, many things that are being done to try and control the COVID epidemic. And it's very clear that the only way we will get on top of TB is if we use this kind of Swiss cheese model for TB, because every single layer that we do has holes in it, like a Swiss cheese. And so one approach is just not going to be sufficient. So there's a lot here. I'm not going to go through all of them, but of course, a few important ones that we need to tackle if we're going to get on top of TB, first of all, is to tackle the social determinants and inequalities. So poverty, crowding, malnutrition, Simon really illustrated the importance of this very well, but this doesn't only exist in prisons, it exists in communities and really needs to be addressed. We need better vaccines, and I'll speak a little bit to that. There needs to be better education. There needs to be much more activism. Many people are just not aware of the issues. And then there are many, many others, including preventive therapy, including early detection of TB disease, the care, the quality care, etc. And so I just want to illustrate the resources that I think should be put towards TB. So here's a comparison, the 1-year comparison of COVID-19 and how much money was put into COVID-19 in the 1 year that we've had this global pandemic. And the estimate that I found was about $90 billion US. Tuberculosis received about $6 billion US in 1 year. So clearly, given the size of the TB epidemic, much more needs to be done to tackle TB. And in fact, we need to be close to $90 billion US. Why can't we get there? So just 2 snippets about how can research help. The first one is that we need to understand the disease better. There are many misunderstandings or simplifications that are just not helping us. So for example, the textbook that you will be reading about TB will tell you that TB exists in 2 binary states or 2 states. Latent infection over here, people that are infected and that can be identified through tests such as TST and IGRA, or active TB disease where a sputum TB diagnostic test is positive. But in reality, Simon already alluded to this as well, it's much more complicated than that. It's actually a whole spectrum with additional states in between that are much more difficult to identify. And the current tests that we have don't allow us to distinguish between these states. In fact, we've been thinking about this in such simple terms. For example, the IGRA or TST testing is positive for all these people here, but some people actually will have eliminated TB, some will be controlling TB, and some will be at very high risk of developing TB, whereas others will have subclinical disease and may actually be transmitting the bacterium. And so we really need to work on ways in which we can identify these different states so that we can appropriately deal with them and come up with interventions. So here's just one example of how we have tried to work on this. So what we did is using blood transcriptomics, so gene expression profiling of people who transitioned from infection to disease, we could track certain genes, and when they go red down here, this is when people move closer to their disease diagnosis, and you can see that it's getting more and more red as you move down. And what this means is that the gene expression is becoming higher. And so we can then measure these genes in the blood and develop a test to try and track people and see if we can classify them into the spectrum that I've just been showing you. And so if we do that, you can see over here that people who don't have TB, actually, if they're asymptomatic, they have no symptoms at all, they have a sort of a lowish score. And then if people are symptomatic, they are slightly higher. If people are at risk of developing incident TB in the next few months, they are even higher. Then people actually have subclinical disease, i.e. their sputum actually has bacteria in it, but they don't yet present with symptoms, then the score's even higher. And finally, when people have active clinical disease that is diagnosed because people are actually presenting as ill, then the scores are the highest. And so this is the kind of tool that one can try and develop, and still needs to be refined and made even better, to try and classify people into these categories. Because then, for example, the people that are in this orange bar would probably need to receive preventive therapy, whereas people in this red bar, which are currently all being missed, should probably be receiving appropriate full TB treatment. So we need to find people with TB, and they are missing because we are missing these asymptomatic subclinical people. We also need to improve the way the way our cure rates are occurring. Many people who actually are diagnosed and receive treatment are just not getting sufficient care and are not able to complete their treatment. And so we have treatment failure. And that's also another problem, a massive problem. And then finally, we really need a better way to prevent TB in those who are already infected. So here's an estimate based on mathematical modeling of the size of the proportion of people that globally that are thought to be infected with TB. These people are not yet sick, but they are at risk of becoming sick. And the number in this particular modeling exercise was 1.7 billion people, or 23% of the global population. So an enormous number of people that deserve treatment or prevention measures to stop them from getting TB. And so one of the things that we've been involved in, along with many other global partners, is to see if we can vaccinate individuals that are already infected, to see if we can get a prevention of progression to active TB. And so this is a vaccine that was developed by GSK. It contains 2 proteins over here that are called MTB39 and MTB32, and it's formulated in an immune boosting formulation called an adjuvant, which is actually created from the bark of this tree. And so we were involved in a phase 2b efficacy trial that enrolled 3,500 adults who all had evidence of TB infection, and they were randomized to either receive the M72 vaccine or placebo. And there was a 36-month follow-up to see whether they developed active disease. So much, much longer than these COVID trials that have been done so rapidly. First of all, just to show you that the immune response that this vaccine induces is actually very promising. So this vaccine induces a very strong CD4 T cell response. It's thought that T cells are very important in protection against disease. In fact, this vaccine was given twice, here at day 0 and at day 30, and you can see that this T cell response is induced and importantly sits around at very high levels up to about 6 months after vaccination. In fact, it lasts much longer, we know. And so this is the type of immune response that we think may protect against TB. And in fact, when we then went on to look at the efficacy of this vaccine, if you know how to read these Kaplan-Meier plots, you will see that in blue here we have the number of TB cases. So every time the line goes down, there are some TB endpoints, i.e. people are developing disease. And you can see that the blue line, the placebos, are developing much more disease than those who received the vaccine. And in fact, this ended up being a 50% efficacy, which doesn't sound great when we think about the COVID efficacy rates that we are getting, but TB is much more difficult to vaccinate again. And so this is actually a really exciting development, because for the first time we have evidence that we can stop people who already are infected from developing active disease through vaccination, through a prevention measure that we can just give twice. Very exciting, and this is leading to a phase 3 study that will start soon next year. So I'll leave it at that, and just to summarize, TB is a major global health emergency. It requires urgent intervention. It requires investment, and it requires a lot more research. There are many things that we still don't understand sufficiently. Classification of the stages of the TB spectrum is really necessary for appropriate intervention. We don't know how to treat people if we don't understand that they're sitting in different stages of the TB spectrum. And vaccination against TB is advancing very slowly compared to the warp speed that we are seeing for COVID-19, but it is going in the correct direction. And I think that in the next 10 years, we will probably have a newly licensed TB vaccine. But clearly much more research is needed. We need to get better than that. So I'll leave it at that, and just again highlight that if we're going to get on top of this, we need to think about this with a Swiss cheese model. We need every single one of these layers which has holes to be filled in so that we can actually get on top of the epidemic. And I'll leave it at that. And thank you very much for the opportunity.
Thank you so much, Prof. Scribbler, for that detailed information on the importance of research and how that can be used to eradicate TB. Next on, we're going to have Dr. Pia Stegler, who is a postdoctoral research fellow working with SATV. She will be sharing with us the experiences of a TB-affected scientist.
Sorry, Dr. Pierre, I think you're still muted.
Sorry about that. I'll share my screen again. So thank you very much for the invitation. And I will tell you a little bit about my personal experience with TB, and that TB is unfortunately a disease that is forgotten in some of the countries. So as you know by now, tuberculosis is a serious global health issue. And as you can see, there are cases in every single country of the world. But what you can also see is that there are huge differences between the countries, with South Africa being one of the countries with the highest burden or incident rate in the world. And when I talk to people here in South Africa, usually people heard about TB or even know what TB is, or some of you know someone who had TB or even had TB themselves. But this is not the case for other parts of the world. So I'm from Germany, and when I tell people in Germany that I'm working on TB, I often get questions, what is TB? Or isn't TB this ancient disease that doesn't exist anymore? And this is not just for Germany. I also lived in New Zealand, where I received similar questions. So in many parts of the world where there's a low incidence rate of TB, TB is unfortunately a forgotten disease. But even if people forgot about the disease, usually the government doesn't. So if you want to migrate to any other country in the world, you will have to provide a proof that you don't have any signs of active TB. And this is not just the case for low incidence countries that are afraid that TB starts to spread there. This is also the case for such high incident countries such as South Africa. So some of you might know this form. It is a radiological report where you have to show an X-ray and prove that you don't have any signs of active pulmonary TB before you enter South Africa. So it makes sense to look at a chest X-ray because mycobacterium tuberculosis is transmitted via droplets and in most cases is manifesting in the lungs. So if you have a healthy lung, your lung tissue is usually appearing black in a chest X-ray. But if you have an infection or had an infection, you have whitish or opaque stains in the lung, which can be caused by fluid consolidation, by scarring, or by cavitation. And here you can see a lung that was damaged by TB. And the lung that you're seeing is actually my personal lung. So although I was born and raised in Germany, I had TB. I developed an active TB when I was about 16 years old. And the issue why my lung is now so damaged and has so much scarring is that I wasn't treated for TB for several months. And this is not because Germany has a bad healthcare system. This is unfortunately just for the simple fact that doctors were not thinking about TB when they treated me. So the first time I was actually hospitalized was not because I had the typical symptoms of TB, such as breathing issues, coughing, night sweat, weight loss, but because I also developed a persistent infection in my ear. And at this time, it also wasn't known that this persistent infection was also caused by TB. So I was treated on intravenous antibiotics for over 2 weeks. And doctors noticed that there wasn't any improvement in my condition. So then they started to wonder what the actual cause is of this infection. And it took a long time and many, many different tests and suggestions. I remember that I was tested, for example, for meningitis. I received a lumbar puncture. I was tested for HIV, but unfortunately, no one came to the idea that it could be actually TB. Until my lucky day that an actually older doctor came and asked me for my symptoms. And she was actually the first one to guess that it could be TB, and she ordered a chest X-ray and a THT test. So this was actually the first time that it was clear that I had TB. So I'm from a town which is very close to Frankfurt. It's basically 20 minutes drive to Frankfurt. So I was assuming that I will be delivered to the university clinic in Frankfurt, which is extremely advanced and up to date with research. But that wasn't the case. If you have TB in Germany, you're sent to this little town here, which is a really small town close to the Alps. So Wangen is one of the few areas which has a sanatorium. And a sanatorium is specialized on lung diseases. So as you can see, it's very beautiful. Patients that are usually delivered into this clinic have to stay for a very long time. So they do their best to entertain people by providing, for example, exercise classes, entertainment for kids, and they even have their own school. But if you're a TB patient, you're unfortunately not one of the patients that can make use of any of these enjoyable activities. So I was delivered to the TB ward, where I received a single room where I had to stay the next 6 months. And the reason why I was staying there so long was that I have to make sure that I don't have any active live bacilli anymore. And at that time, gene expert was unfortunately not a thing. So I had to provide 3 cultures that were negative. And every culture itself takes about 3 to 4 weeks. But although the disease was diagnosed so late, I recovered, and that is the good thing about TB. TB is a disease that can be treated. And although TB is a curable disease, it's still the leading cause of natural death here in South Africa. And when we think about the impact of TB, we often count it in the number of deaths it is causing. But what we do forget is TB is also the leading cause of disability here in South Africa, which is ranking here at place number 4. And also for me, TB had a life-changing impact. There's actually not one single day where I do not remember that I had TB. So first of all, I'm deaf on my right ear because of the tuberculoid mastoiditis. And then my lung volume is severely compromised. I have only about 20% of my normal capacity left. And my physical impairment, of course, is influencing my social life. So I'm not able to exercise, I'm not able to go for a hike with friends, I'm not even able to walk long distance without being completely exhausted. But these are kind of luxury problems when you think about that people here sometimes are physically impaired, are not able to continue their work. They might have to quit their work because they're too weak, which of course is a huge financial burden, not just for the individual, but for the whole family. And all of these events, of course, have a huge impact on the mental well-being of someone, and probably also on the whole family of the person affected. But for me personally, I can say TB was not just all bad, and I hope that most of you can say that every bad situation has something positive. TB led me to where I am now. So after the hospital, I kept still asking myself the question, why was my immune system not able to clear the bacilli? Why did it take so long to diagnose the disease? And why is there no vaccine that can protect us against such a severe disease? And I'm happy that I can now address all these questions here at ZV. And I'm always grateful to see that there are so many people here that are very passionate about TB, not just at ZV, also at the IDM, at the whole university, and even beyond. So I'm really happy to see that there are a lot of people here in South Africa that are passionate to work towards having a world without TB. Thank you.
Thank you so much, Dr. Pia. I am sorry that you had to go through that, but at the same time, I'm also glad that you took it and you were able to join other people who are working with TB to make a positive impact. Thank you so much for that.